May we now call upon our next speaker, Dr. Rajpal Abhichand.
Good afternoon, everybody, and it's a pleasure to be here. And I'd like to thank Dr. Srinivas Kumar and Team ACVS for giving me this opportunity to be with you. So over the next 10 minutes, hopefully we will go through some important aspects of left main angioplasty. So to begin with, the first important thing is, whenever you are embarking on a left main angioplasty, look at your angiogram. Look at your angiogram again and again. This is of paramount importance. Look at your patient. Look at IVUS before the procedure. Look at IVUS after the procedure. And finally, the fifth point will be, do not push it if you cannot handle it. I think it's very important to keep in mind, especially this IVUS, because till we got IVUS, we did not really realize how useful IVUS can be. I'll come to that. When you look at your angiogram again and again and again, you must realize that left main angioplasty is not a homogeneous entity. You are looking at ostial and body angioplasty, ostial and shaft, and distal. So these are, yeah, can you have the lights down, please? So these are actually two separate entities. So if you look at it, the ostial and body angioplasty of a left main is a single stent strategy. Is it clear? Can you see now? Can you have the, yeah, that's fine. So ostial and body is a single stent strategy, whereas a distal angioplasty of the left main is a bifurcational angioplasty, and either can be one stent or two stents. These are two totally different strategies and totally different entities. Why so? If you look at the ostial left main multicenter registry, the restenosis following a left main ostial angioplasty at the end of 6 months is very low. It is 1%. I mean, this is something that is God sent. Imagine having a left main angioplasty done with a risk of restenosis of 1%. I agree this is 6 months, but what is very clear is left main ostial angioplasty restenosis is very less, because most of the time the ostium is more fibrotic and not much calcific, and therefore restenosis is less, because these these come in from the aorta. Whereas ostium and mid shaft, the 9-month target vesicular revascularization TVR is around 4 to 5%, which is still low. When the stent is not opposed to the wall, the drug doesn't elute effectively, and therefore restenosis is higher. So restenosis is higher at the circ ostium, actually, which is not so, I mean, it's not a nice thing to have, but it still can be benign in a relative number of patients. So now, having looked at your angiogram, look at it again, because you do not want to do a left main angioplasty on a small vessel. If at the end of the angioplasty you feel you are not able to get a minimal luminal diameter around 3.5 to 4, better not to do that, because the results are not very good. And then I'll come to the IVUS findings later. Of course, a bifurcation, LV dysfunction, and requirement of multiple dilation increases the risk of these procedures. So when you have seen your angiogram again and again, avoid small left mains, calcific left mains. Try to keep it to a single stent strategy. This is the best. Keep your strategy in mind, keep your views in mind. Make sure you have an adequate size stent. This is so common that if you have a left main ostium and you need a 12 millimeter stent or a smaller stent and you don't have it, you have only a 15 millimeter stent. So then either you are hanging in the aorta or you are making it a bifurcation when it is not there. This is something very important. Keep an adequate sized stent on the shelf. Make sure you have a 4.5 or even a 5 millimeter non-compliant balloon on the shelf before you go in for an angioplasty. This is so important, as you will see later. If you do not, if you are unable to post-dilate properly, and if you do not have these 4.5 or 5 millimeter non-compliant balloons, then it's not worth doing it. Of course, when you look at these strategies, if you have just, say, you can have a circumflex is not diseased, single stent, circumflex is diseased, then if the left main is big, you go for a kissing or a V. If it's small, I would say just a crush stenting. All these other strategies are not really very, very good. So this is a left main ostium. You got a left main ostium, single stent, direct stent, balloon dilatation. You have a good result. This is a shaft. Shaft angioplasty. Again, is fairly straightforward. If you choose the length and diameter of the stent well, it's fairly straightforward. And then, now, when you come to an unprotected left vein with a distal bifurcation, with some circ involvement, then if the left vein is not big, this strategy would be a crush technique. Actually, a mini crush would be an ideal technique here, and the results are quite gratifying. Now, suppose you have a situation where the left vein is large, and you have a circ ostium and something, LAD ostium and circ ostium. A good technique will be to do a kissing stent, either V or a kissing or SKS, whatever you call it. The results are quite good, but this necessitates one to have a commodious and fairly large left main. Now, if you see a left main like this with a distal bifurcation, with a distal left main, circumflex fairly free of disease, go for a single stent strategy, stent across the left, the circ ostium, and well, I still think we should end with a kiss and make sure that things are all right. Now, after looking at the angiogram, and probably this should have come first, you should look at your patient. Make sure that risk factors, very old, renal failure, emergency, cardiogenic shock, these are high risk patients for left main angioplasty. Make sure that these patients need dual antiplatelet drugs for at least 1 year, if not indefinitely. So if this patient is going to go for some cancer surgery or prostate or some major surgery, think about your options, whether you can offer dual antiplatelet therapy for at least 1 year. Now, IVUS, actually before we got our IVUS machine, we were doing, and then angioplasty, but still, after we got our IVUS going, it's very important to realize there are some patients where you can avoid angioplasty if the literature study showed a minimal luminal area of less than 6, there was benefit. Between 6 and 7.5, questionables, more than 7.5 clearly differ. This has been challenged now. If you look at Park's criteria, he combined FFR and IVUS. So this is IVUS before the procedure. If you are looking at an FFR of less than 0.75, it correlates with a minimal luminal area of 4.1 and a plaque burden of more than 76%. Now, what about IVUS after PCI? IVUS after PCI, you have to follow the 5, 6, 7, and 8 rule. If you follow this, even in a bifurcation angioplasty, the restenosis rates and target TLRs are quite low. Say the restenosis rate is around 5% and TLR of 2, which is really low. But you have to keep this in mind. Your left main post-procedure, you must get, when you have stented the entire carina, and it's a bifurcation angioplasty, where the risk of restenosis is higher. But following IVUS, if you are able to optimize your result and get an 8 square centimeter in the left main, 7 in the bifurcation, 6 in the LAD, and 5 in the circ. So the 5, 6, 7, 8 rule, if you're able to follow this, then your TLR at the end of 1 year is 2%. So which is very, very good. Finally, in this litigious era, do not hesitate to take a consultation from your colleagues, your surgeon. It doesn't matter, and document it, because when things go wrong, you should not be caught with in an unfamiliar situation. So it doesn't hurt that you have taken a colleague's impression and noted it down, documented in the case sheet. And lastly, don't push it. Don't enforce too much with indication, with devices, techniques, or eagerness to do a procedure. Otherwise, everything will pop out and things will not be very good. So thank you for your patient listening. If you have any questions, we can take maybe just one question. Yes, that would be a difficult thing to do, especially if it's diffusely diseased. But one thing that I would like to keep in mind is if your left main is diffusely diseased and you feel you will not get at the end of the procedure, you will not get a 3.6 millimeter left main, this is a left main you should stay away from. This is a left main you should stay away from and not get into it. But otherwise, IVUS would help in sizing to some extent. Yes, sir. Yeah, I still believe it is possible to do it, and it still can be done. There is no 100% recommendation that you cannot do a left main angioplasty in the absence of IVUS in your lab. But I believe if you have done some IVUS or a good amount of IVUS, and then you take on an angioplasty without IVUS, then you will know that IVUS has helped you, and then you will probably optimize your result better. But still, I think it can be done.
Strategy in a stable angina sort of a left main situation. It's not ACS.
Yeah.
Would you prefer to have these patients on clopidogrel and do a clopidogrel unresponsiveness study, like a platelet aggregation study or a polymorphism?
Sorry, your question was duration of antiplatelet therapy.
No. The choice of dual antiplatelet. I mean, would you still stick to clopidogrel in all these left main stented patients, or who are in a stable angina situation, not ACS?
Yeah, in stable angina, what is the choice of antiplatelet therapy? Is that your question?
Yeah.
See, I don't think, I could not come out with any reference for ticagrelor in this situation. But considering that ticagrelor is a superior drug, as far as I think it would be the best choice. But definitely there is evidence to say that your stent thrombosis risk and risk of problems increase in a left main with clopidogrel alone, with clopidogrel and aspirin. So it's better to go either with prasugrel or maybe with ticagrelor.
Can I add something to that? Actually, left main is so roomy, close to the aorta, the pressures are so high, and the stent size is so big. The least thrombosis chance that you see is generally left main. We are very scared that left main is going to thrombose. But actually, if you have done a good job, the least thrombosis that happens in any stent is the left main stent.
Even the distal left main bifurcation?
Yeah, see, a complex case if you do, but it's a single stent strategy, yes.
The last one, please, Dr. A.B. Mehta will be next, the last one.
Do you regularly direct the studs towards the circ in a single stent strategy?
See, that I don't think we have the answer to that yet, as of yet, but with what evidence we have, we should end a left main angioplasty with a kiss in the circumflex. But there are some people who believe that this may not be necessary, but till we have evidence in favor of that, right now current evidence indicates you must end with a kiss.